As time has gone on, we've seen different aspects of privatisation have become more and more to the fore, and now it's quite a long and complex process over those 40 years, and we're still these days dealing with aspects of that, which I'll come back to towards the end. So this is my first chance to pull it all together, and it was something of a shock to find out it's 55,000 words long, and to try to summarise it in 15 minutes is not going to happen. So I'm just going to touch on some points which are hopefully relevant and link it in. And the first thing is that you will see in the report that it breaks it down into non-clinical services, which was the first area of privatisation by the Thatcher government, and the first area singled out for attack. And there were many reasons behind that. Firstly, there was the question of supposedly, well, actually implementing Thatcher's neoliberal, what is now called neoliberal policies, and actually attacking a part of the public sector. But there was also the question of breaking up the workforce in the NHS, which in 1982 had staged a whole series of quite militant disputes in which the ancillary staff, the support staff, had been the best organised and the leading elements. So this was separating them off from the other unions, which of course alongside the Tory anti-union laws meant that you're actually in a position to really weaken the prospect of national fights over pay and conditions in the NHS. So that was also important. Also, a not unimportant point, was it then provided the possibility of contracts for Tory cronies and MPs to sit on boards of privatising companies and so forth, and that became a significant factor as time went on. But in order to drive that through, they had to continually shift the goalposts and pressurise the management of the NHS, which at that point was integrated into health authorities, and persuade them to actually put these services out to tender. But not only that, but to take the lowest tender in each case and have a reason, explain to ministers why you weren't taking the lowest tender. That was effectively the pressure that was being put on. And under those circumstances, it's remarkable how much resistance came, not just from the staff themselves, who in many cases fought back, and the whole wave of disputes in 1985, 4, 5, 6, against privatisation. And of course, the fight back against that has continued ever since. But it's also the management were very reluctant to do this because they were breaking up the teams that they'd worked with. They knew the problems of controlling people who weren't their staff and actually trying to get them to work as part of the hospital setup. And so there was a great resistance from management, and they've never succeeded, despite all the pressures, despite all the moving of the goalposts, they've never succeeded in privatising all of the staff in the NHS. In fact, the most recent figures show that 66% of staff in estates and facilities management, which is the type of services we're talking about, 66% are still directly employed by the NHS. 27% are outsourced to private companies, and 7% are part of what we call now subsidiary organisations, subsidiary companies, subcos, and I'll come back to that a bit later on. So what do we mean by privatisation? It's an important one to start with because obviously ministers of both parties have always said, oh, well, we're not privatising the NHS because it's still free to access and so forth. And of course, it wasn't the same privatisation that took place in the big national utilities and so on, which they actually literally carved them up into shares, sold shares and made them into private companies. That hasn't happened to the NHS, and I don't think actually any government really seriously tried to take that on for the NHS. Nor would actually many big companies or banks fancy the chances of making money out of the NHS, given the way it's been funded and the gaps that have been created in it over the many years. So it's rather different. This is a question of carving out discrete bits of the NHS that were previously delivered by the NHS's own staff and handing those as contracts out to private contractors. Now, that is rather different. So it's not being sold off. It's being contracted out. And I think that's really quite important because however bad the privatisation has been, there's been some disastrous measures have been taken. There's always a possibility of ending the contract and bringing it back in-house. And at the end of the day, those contractors don't own any part of the NHS. They're not shareholders. They don't actually own anything. They only get a new contract insofar as they can satisfy the commissioners that they're worthy of that contract. Now, admittedly, the bar for that has been set pretty damn low by some of the employers and NHS employers over the years, but that is still a factor. So this is still, it means it's possible to reverse this. And of course, unions like UVW and others have actually succeeded in doing that. And some of the TUC unions have also succeeded in doing that over the years. And it's not just when contracts have failed, but it's when pressure has been put on to actually keep those or bring those services back in-house. So I think that's a really important distinction. And it's easy to say the NHS being sold off. But actually, you know, if you take the sell-off analogy further, they're not being sold off to the highest bidder, they're being contracted out to the lowest bidder. It's quite the opposite process, and it's a process that guarantees, if you always kind of contract out to the lowest bidder, guarantees you get the worst possible service. You can't possibly bring quality into the equation if you've got to put price first, and it's the only criterion for what you're choosing to do. So privatisation also hasn't always been with us. It began, in theory, it began in 1982-83. In practice, it began in 1984 with the first disputes, as I mentioned. The first disputes began, and the first real substantial moves by NHS employers, health authorities, to actually privatise cleaning, catering and laundry services. These were the main ones that went out to begin with. And it was a policy shift that reflected the Thatcher government's idea of breaking with the post-war consensus, but also with as I said, the undermining of the strength of the unions and the unity of the NHS workforce in order to maximise opportunities for profit. So in order to prepare the ground for this, we suddenly started hearing about cleaning and catering services in hospitals being referred to as hotel services, right? Well, you know, it's laughable, isn't it, really? The idea, any comparison with the hospitals of then or now with a hotel is a joke. But actually that was argued because it was the idea of separating them from the clinical staff, separating out this as if it was some completely different thing, as if when you actually decide to contract out and less hours are worked by the contracted staff, those jobs are picked up by the clinical staff. You do have an impact on clinical care. And you know, where it's not done by the cleaning staff because they haven't got enough time, because there's not enough staff, because there's nobody there, because that's not the hours they're supposed to be working on the ward, then the clinical staff wind up having to do that. And that's actually what happens time and again. It's why even the Royal College of Nursing, which was very late on the scene, eventually realised they ought to be opposing privatisation too, because their members hated it. And they lost control of the staff on the wards, but they'd also were in many cases having to delegate nursing staff to do cleaning jobs and other jobs, which they were paid more than that as well. You know, economically, it didn't make any great sense. So privatisation, as I said, required the splitting of the NHS into separate units, creation of a market of some sort. This began with Thatcher's internal market. As Thatcher's reforms are actually implemented under John Major's government from 1991 and created a so-called internal market in which they split out the purchasers, which was the health authorities, from the providers, which was going to be NHS trusts that began life at that point. They didn't exist prior to then. So this was 1989 to 91. 91 was the first trusts began to be set up. Guy's and St Thomas's was one of the first to go, and immediately began with a wave of redundancies as soon as they'd launched the trust, because they'd launched it on a prospectus that didn't actually hold water, and so forth. So trusts and the whole creation of this internal market has always gone hand in hand with tightening financial constraints and looking for ways of actually saving money at the expense of frontline staff. So New Labour then deepened this from 2000 with the NHS plan of 2000, began to develop a much more open market, which actually brought the private sector into clinical work for the first time. So this hadn't been done before. So suddenly you could actually get contracts out for diagnostic and treatment centres, for the Concord Act was signed with private hospitals to take people off the NHS NHS patients off the waiting list during peak times, but eye-watering increases in costs in the region of 40% higher than NHS standard costs. You can understand that the trusts of the day were not keen to do this, and there was great resistance to carrying this through, but it was pressure from the top, signed by Alan Milburn as Health Secretary in 2000 as a great step forward. Then came, as I say, the diagnostic and treatment centres, scanning machines going around on the back of lorries and so forth, pulling up in hospital car parks. You could literally get your scan off the back of a lorry in a hospital car park. And this was seen as, again, a step forward. And of course, Allied Medical and other companies made a lot of money out of doing that, and then contracting out the actual reading of the scans to as far afield as South Africa and around the world, getting consultants elsewhere to actually read those images. And also then independent sector treatment centres came along. This was setting up new privately run organisations to deliver elective operations at around 11 to 12% more average price than the NHS was paying. They were guaranteed a contract, the life of the contract, and they were guaranteed a turnover, a number of patients that would be paid for, regardless of who turned up. So again, the private sector was very keen to move in on this. And this was a new way of actually drawing money out of the NHS and leaving behind, of course, all of the more complicated cases, all of the difficult workload the private sector's never wanted to do, all remain, and of course, all the emergency work and maternity cases and the serious mental health cases all stayed within the NHS. Everything else could be done, and they had a screening system for making sure only the least serious cases, the least complex cases were referred to private providers. Then from 2005 onwards came a real push to privatise community services, community health services, and a range of services that are outside of hospital but actually delivered by the NHS, bit by bit, were contracted out. And some were given to community interest companies, so-called non-profit organisations, which still had to function in the market, still had to compete with the private sector for contracts. And so on. So the worsening of conditions still continued even then. And then, of course, alongside that, there were efforts to bring the private sector, initially United Health from the United States, Virgin and other companies, into primary care. Now, this has fallen on its face several times, and it's again fallen on its face relatively recently, because there was another effort a few years ago to do this. Centene that bought a whole load of GP surgery. I say a whole load, this is 50 out of several thousand. So it's like 1% of GP surgeries and so forth. But it seemed like a significant inroad at the time. Then did a review and decided they weren't making enough profit in Britain or anywhere else in the world other than the United States, and just shut everything down and sold it off. So that's been in and out. But primary care potentially can be now also under APMS contracts, alternative medical service contracts, can actually be privatised and handed over to companies to take over for profit. Of course, because companies can make the profit by diluting the skill mix of staff they employ, fewer fully qualified GPs, and getting them to work under more onerous conditions, more and more delegated out to staff other than GPs to do the work. Including physicians' associates these days as well. So you've got all of that side of things as well. From 2010, this went on to Cameron, Lansley, and of course the great Lansley reforms, a complete top-down reorganisation of the NHS, so big you could see it from space, somebody said, and which aimed to entrench the competitive market and actually outlaw any collaboration and joint work between NHS trusts. They were supposed to definitely not work together. The Competition and Markets Authority was set up to scrutinise what they were doing as well as monitor as a regulator, and they were told they weren't supposed to be doing that. And then at the same time, you had a pressure on the clinical commissioning groups that were set up. Remember them? It wasn't that long ago. The clinical commissioning groups was this long succession of different acronyms for all these different organisations that effectively wound up carving up more or less the same work between them. And we're going around big, ever-increasing circles. CCGs were expected to commission more and more, put more contracts out to tender, clinical care contracts out to tender. And there was an initial big surge in community contracts, again, that went out under this, and some increase in the total amounts being spent with the private sector. But interestingly, that tailed off after a while, and the large number of the community contracts were quite small. The NHS remained the main provider of community services but actually still had a very large number of these contracts contracted out, with the staff, of course, dumped into private companies, which again, under the stock formula, look for ways of employing fewer staff, getting them to work harder, and giving them as little as possible in terms of pay. I'm just realising I'm running out of time, and we only got halfway through. So I'm going to whip on, because this is the basics. Now, there were big setbacks. There have been a whole series of setbacks. All along the line of the awarding of these contracts to private providers, there have been a string of failures. And it's always never enough to just look at adding up the numbers of contracts and what they were worth that's being handed out. You always have to look and see how long they lasted and what happened to them, because a lot of them don't last the course. So in 2013, 2014, we had Serco in Suffolk, which had a community services contract, gave it back because they were not making any money, losing money. They gave it back and decided to pull out of all clinical work. In 2014, we had the Hinchingbrook Hospital, which had been handed over to a private company, Circle, to run it, and a complete disaster. And the Circle walked away, paid £2 million extra to walk away, having lost money and never made a penny profit on the deal. 2015, we had in Sussex, a major support services contract to hospitals in Sussex collapsed, and Sodexo were kicked out. In 2016, in Leicestershire, Interserve, a massive contract again for Leicestershire hospitals, again lost that contract after months and months of dreadful quality services being exposed. And were chucked out. In 2016 also, in Nottingham, University Hospitals, Carillion lost a massive contract. Then 2018, of course, the big collapse of the lot, which Carillion actually went bust, and taking with it, of course, the hopes of further PFI contracts. Carillion was the major holder of PFI contracts. They went bust, left hospitals half-built, or not even half-built, and created a massive crisis. And I think we can give them credit for killing off PFI in the way we used to be. I think that's probably a good thing. I haven't got time to go into PFI now. I just want to come back to subcos, because this is a more recent one. Subcos is where you get a trust is persuaded to transfer their staff to a wholly owned company, which is, strictly speaking, not part of the trust, but get them to do the work, effectively contracted out. They lose their NHS status, they lose their NHS pensions, although some of them have actually been done on NHS terms and conditions and have actually managed to do it. Now, how do they make money on this? Well, to save money on this, they save money by dodging VAT. It's a massive VAT dodge. And if you don't believe, if you think I'm making that up, you just had to listen to Jim Mackey, the new Chief Executive of NHS England, who last week was saying, we want, as part of our drive to save money, want all the trusts to actually transfer their staff into subcos because they can escape VAT. It's actually specifically what he said in the speech, which is quite remarkable. I'm sure the Treasury will need to be ringing him up to find out what's going on with VAT payments. But also because, of course, new staff that they employ after transferring them into a subco don't have to be employed on NHS terms and conditions, because they can then actually be employed, and the two-tier workforce is absolutely central to that. Also, right at the moment, we've got an ongoing dispute in Colchester in Essex, where the trust has decided, which brought all their staff back in-house in 2011 and made a big song and dance about what a great thing it was, have just decided to outsource all their support staff and on the basis of a completely trumped-up business case. That it turns out even their full business case exposed the nonsense in the preliminary business case that they'd done it all with, done it all through secret session of the trust. And when the workers actually called on the government to actually intervene and rescue them, nothing's been done at all, despite, of course, the Labour government notionally being pledged to actually the biggest wave of insourcing history has ever seen. Well, we're still waiting for that to start, and I suggest you don't hold your breath waiting for it to start. So just finally, I just want to tie in with obviously what the report was commissioned to do, which was to expose the background to the way staff were treated, and particularly support staff represented by the three unions were treated during the COVID pandemic. And I think this is really important, because what you got was a complete continuation of all the worst practice we had from the 1980s and the 1990s. All the ways in which staff were treated as second class, pushed into, they got the worst access to PPE. They had sick pay, which was statutory minimum sick pay, which meant few of them could afford to take time off when they were sick, which put them, their colleagues and their patients at risk, and was clearly unacceptable. They got abused right up to and after the end of the pandemic, when, of course, the rest of the NHS all got a £1,650 payout, and the contracted staff, each of them had to fight and threaten and take strike action in some cases against their employers in order to get the payment, even though the government had given the companies the money. This is the way they were treated. And of course, the worst access to PPE was traumatic for many of these staff, particularly because obviously, especially in London, but around the country, these staff tend to be from the minority ethnic groups, which are actually most susceptible to the COVID virus and were most intimidated by it. And to not be able to actually access the proper protection, while clinical staff were given it, even after great delays, this was a massive stress. So this doesn't come out of nowhere. This comes out of the 30 or so years, the 40 years of privatisation that precedes it. And it spells out why we can't have an NHS which is integrated, which is efficient, which is effective, that gives good treatment to patients and also looks after its staff, if we have this continuation of a two-tier workforce, the continuity of second-class citizens amongst the workforce of the NHS. That's why it's such an important fight for all of us, for patients, for the general public, and for the rest of the NHS staff to take this on. And that's why I'm so pleased to be able to offer my small contribution towards that fight, which I know that the colleagues are actually taking on the ground on a day-to-day basis. So thank you very much.